this better? Better, sir.
Today's speaker is Dr. Sadhana Bhatkhande. She is the head of Community Development and Social Service Department at KEM Hospital. She is very well qualified in social work. She has done training for trainers on HIV, AIDS in 2003. She has done advanced certificate course in social work research in 2010. She is trained in REBT in 2012, and she has been recognized as a rehabilitation social worker by Rehabilitation Council of India in 2006, and she has done PhD in social work in 2009, and she has been associated with many committees like Institutional Ethics Committee, like Women Development Cell, and many other committees at KEM Hospital. And she is also attached with certain NGOs like Yuva Parivartan, Anandham, and Chaitanya as a volunteer. And it is nice to have uh, such a person to talk about the psychoeducation, which is a very important aspect of psychiatric uh, psychiatrist and the patient interaction, and very important issue in managing lots of issues like negative emotions in patients, uh, patients' rehabilitation after recovery, and also plays a very important role in maintenance treatment of various major psychiatric illnesses like schizophrenia and bipolar mood disorder and recurrent depression. So all these uh, issues are important, and we as psychiatrists should also be aware of those issues. And really, we are very happy to have Madam as a guest speaker today. So welcome, Madam.
Thank you very much, sir. Thank you.
Just a word before Sadhana begins. I know Sadhana since I joined psychiatry, which was in 93, way back in 1993, and Sadhana was already there as a psychiatric social worker. And I have learned my psychoeducation and psychosocial interventions from her. And we have numerous cases on which we have worked together and brought them back, and we have patients' relatives who we have worked together on. So I'm really happy to have Sadhana here, and I just hope that all the residents learn from this and not forget that psychosocial intervention as well as psychoeducation for the caregivers is equally important, because they also go through a lot of pain, physical, emotional, and of course they have social issues, financial issues, and Sadhana has been dealing with them for years together. So welcome, Sadhana, and over to you.
Yeah, thank you very much. Good evening, all of you. At the outset, I thank the organizers, especially Dr. Shilpa, who has been very closely associated with all that I have done in KEM. And thank you for this opportunity. And today I'm here to talk on this important topic, which is very close to my heart, psychoeducation for patients and caregivers. I will share few slides. whenever I deal with my patients, am I audible? Am
Yes,
I
yes.
audible?
Yes,
Yes.
you are. Please go ahead.
Yeah. Whenever I deal with patients and the relatives, I remember Kabir Doha, Sant Kabir Doha, Ghayal ki gati ghayal jane na anya koe. So the suffering can be only empathized when you have people around that person who have also suffered or who have also known the pain of going through it. So we have in KM and in psychiatric setup, we have been seeing a lot of cases. But then I remember my old days when I was posted in Sion Hospital as a student under Dr. Usha Dharmadhikari. That was the ENT department. And there in that ENT department, we used to run a Palak Gut. That Palak Gut was for the parents of children with deafness. Now, here in this group, the purpose was to help the parents deal with this trauma of having a child with deafness. Now, when I introduce this topic, I want to bring about three things. First is the situation or the condition that is causing psychological stress. Secondly, not only the emotions or the psychological aspects, but the whole list of information that is needed, the knowledge about the disorder or the pain that person is going through. And thirdly, the chronicity of the illness or the situation which may continue for the lifetime. So the whole purpose of knowing this is there are 6 things that I have put down here. One is awareness building, awareness regarding the problem that the person is going through, how to cope, the coping strategies, treatment options available, and also how and when to seek treatment, need for adherence, and long-term course. Now, with this Palak Gut, we used to cover whole lot of information right from the pregnancy, care to be taken at the time of pregnancy, birth of a child, developmental milestones, causes which were known and unknown regarding deafness, then educational methods, communication methods, laws pertaining to disability, sign language, and many other things. Now, this was effective when we saw that number of parents started enrolling children in special schools as well as in the normal schools where there was this inclusion policy which was coming then. So that was my first experience of conducting a session with the caregivers. The second experience was in the orthopedic setup where I started organizing and dealing with a group of amputees. In the orthopedic setup, all those who were suffering from a loss of limb, they were grouped together and we started working on their rehabilitation. So prior to rehabilitation, what, how, when, which source, all those things were addressed. Now, when I'm here in this my journey, I see restaurants like Mirchi and Mine, which is a chain of restaurants, which is run by the deaf population. And I remember when it was started, that time it was only 11 employees who were deaf who were employed in that hotel, I mean the restaurant. And Nasio conducted a job mela, and there hundreds of people, hundreds of deaf youth, they joined and they enrolled for this employment. So spreading word, spreading information, spreading.
This is the PDF mail which contains all the slides and Prinjapa is working on getting it shared on the screen. I think this Yes, the screen share has started now.
Yes, now we can visualize a slide which is called purpose.
Yeah.
Okay.
So the purpose for this presentation is, of course, to know, spread awareness, also to cope with the situation which is difficult, which is psychologically pressing, then the treatment available, when and how to seek treatment, need for adherence, and also what all happens during the course of treatment. People have a lot of questions, people have a lot of doubts, people want a space to talk about it to somebody who can guide them through, because the course of illness is very long. So as I discussed that it is not only the mental health professional who conducts psychoeducation groups, it is all health professionals who are dealing with difficult life situations, pressing life situations due to some disorder or some psychological pain. They all benefit with psychoeducation. As I discussed, it was in the ENT department. We started with Palakgat of children with deafness, and then the group of amputees who suffered from loss of limb, and we continued with them for a long time. The next slide. Here there are some contents which I have put down. Now in the introduction, as I discussed that it is the psychological pain, it is not the psychotherapy that we are dealing with. It is a huge information about the illness, how it starts, why it starts, what are the causative factors, how one has to deal with it, what is the role of a treatment, the medication, and also the psychological and social aspects which are covered in these groups. The next. As I have put down here, if I want to compile all these three, introduction, purpose, and definition, I can say psychoeducation for the groups is useful for motivational, educative, and it is a client-centered CBT-based model which helps patients and the relatives. Now, what are the factors that we look at when we conduct certain groups? It is the community support that we are looking at, because we see patients in numbers, large numbers, and they cannot be attended one by one individually all the time. So community support is one first challenge that all of us have. So they all can connect and share their experiences and benefit with the sense of belongingness, especially when these are the marginalized groups who are isolated population. Why isolated? Because somebody suffering from a particular trauma starts loaning or starts keeping away from the normal set of people. Secondly, there is peer learning possible. They learn from each other and they learn good coping strategies to improve and work better and work as people, stronger people. There is skill development possible, which provides opportunities to practice social skills, communication, empathy, conflict resolution, and safe, supportive environment is provided. Now, this is very important, normalization of experience. When somebody is...
do we have to move the slide?
Yeah, please. Yeah. To normalize the experience, they get to know that they are not alone in their struggle. It reduces the feeling of isolation, stigma, and promotes acceptance. It is also cost effective. Mental health services are more accessible to a broader range of individuals, and affordability is handled well. And also, there are diversity of perspectives. Individuals from diverse backgrounds, cultures, experiences, they exchange ideas, they share with each other what happens in their set of life and how they deal with the problems which keep pressing them. So there are so many advantages. I mean, the definition and the goals that we are talking about has a huge role when we talk about psychoeducation. Only treatment, only medication doesn't help. It has to be covered with the information which is given in an empathetic manner. Understanding what is an illness, the treatment methods to deal with it, responsible handling to attend OPDs, clinics, and provide treatment. Also, empathizing with the patient's role and the caregiver's role, providing insight into the illness, helping them the relationship to understand the relationship between the treatment and improvement in the symptoms is also very important. And one important area is relapse prevention, which is possible if there is a regular concern given to them with through the psychoeducation groups. Next slide. Now here I remember Marathi poet Suresh Bhatt, who in his poem says, भोगले जे दुःख त्याला सुख म्हणावे लागले, एवढे मी भोगले की मज हसावे लागले. लोक भेटायास आले काढत्या पायासवे, अन अखेरी कुशल माझे मज पुसावे लागले. Now in this poem he describes that when a person is suffering, it is very lonely over there, and one has to deal with all those traumatic experiences, handle them all alone. But psychoeducation groups provide a good support. People feel more relaxed, they feel in control of the condition, they are more likely to actively participate in self-management. They experience that the medications are working, there is a behavior change, there is an improvement in behavior, there are positive feelings, person becomes socially positive, self-esteem changes, it reduces stigma. How it reduces stigma? As I said, it gives a normalization experience. So it is not only me who is suffering from this. Simple example, if a child is scolded or punished in a classroom, the child feels horrible if he is all alone. But if there are 3 more children or 5 more children who are also punished, the students feel good. In the sense, they feel okay. It is okay to get punishment. So similarly, when our caregivers see 10 other members who are also going through the similar kind of a pain or trauma, they are able to better accept it. So there is a relationship. What is this relationship? Dard ka rishta we can call, and they share and help each other go through the similar kind of a pain. So it reduces social stigma, promotes awareness, and prevents emergencies. There is less number of hospital admissions, and hospital stay is also reduced. Next slide. There are certain principles that one has to remember while conducting these sessions. People don't like preaching. We don't have to guide them all the time. So when we start such groups, we always encourage caregivers, the participants, to share their experience, to talk about the problem that they are going through. So the beginning of the group is with their participation. So they start feeling that we all are equal. The therapist is going to listen to them and other members are also equally involved. Consumer as an expert. Now, who is this consumer? It could be the patient or the caregiver. Who is an expert? Why? Because the situation that the person is going through, that is his own situation. So he knows everything in that. So giving importance to that person is most important. We elicit relationships, experiences, and understandings about the disease, about the illness, and also by principle, we also give high regards to the person's patient handling of the person who is suffering. As Gandhiji has said, patience is to lose, if to lose patience is to lose battle. So they are encouraged to believe this, that they can, this situation also will pass away. To avoid conflict and confrontation, it is one principle that within the group there is a give and take of information, but the conflicts are avoided. Now, evaluation of understanding. There is a review material. A group may be floating, like there may be a different set of caregivers who participate, but there is always information and material shared to review and evaluate the group process. Next. Psychoeducation is conducted in groups and also individually. There are some caregivers who require individual support. So psychoeducation is also conducted for families and group members and also friends and other caregivers. Sometimes we have distant family members or the relatives who are not directly related to the patient, but they are the caregivers. So psychoeducation has to be planned for all these other members who are involved in the caregiving process. The next. There are certain issues which we constantly deal with when we group them. So our approaches change as per the social attitudes that they have. Also, sometimes the financial difficulties that they have in availing the treatment for the mental illness. And there is something called as they have to learn to pardon themselves. Sometimes there are huge emotions which are negative in the caregiver's minds. So one has to deal with all these three things. Now, what are the contraindications? Who cannot become the participants of these psychoeducation groups? All those patients who have massive thought disturbances, people having mania with elevated mood, patients hearing imperative voices, patients with active suicidal idea, and caregiver with compromised mental health. Next. Now, what happens when we conduct these sessions? The outcome is that there is information transfer. We inform them about what are the signs and symptoms because they start sharing them. Then we discuss the causes. Then we also share the treatment possible, which is offered in the setup, the side effects of the treatment, how and why the side effects and how to deal with them. And then the daily living, the emotional discharge, the emotional aspects, the support systems, which are important. Issues like patients' routine, communication patterns at home, and very importantly, expressed emotions. So in the group, there is assistance provided to handle all these different stages patients have, the caregivers have a lot of questions regarding the symptoms of the patient. Sometimes they say that so and so is very, very suspicious. He doesn't let us give the tablets. So now in such situations, there are some ready answers. There are some interactions between the therapist and the other family members who are also attending the group. So there is a good sharing when they say that, yes, we provide the drugs, we give them in the food, or we, with the help of therapist, that the therapist suggests that maybe some injectables are introduced and things like that. So there is a healthy discussion regarding how to tackle these issues. Next. These kinds of posters are also used when we conduct such sessions. Now they, in a very simple manner, explain the biopsychosocial model, biopsychosocial causes of different disorders. And we also relate to so many medical illnesses, physical illnesses like tuberculosis, where the biological aspect is the tuberculosis bacilli. There are some psychological aspects where the patient has neglected his own health, and there are certain social aspects where he is living in compromised household. Similarly, in mental illness also, the chemical imbalance in the brain or hereditary factors play an important role. That is the biology. So these kinds of posters are used to explain this so that the information sinks in that it is the illness and it is nothing like Karni, Bhut Badha, because our population is highly prejudiced with all these information shared by everybody and everybody. Mainly because mental illness cannot be seen. It cannot be measured like temperature or blood test. There is no injury. So it is very difficult for caregivers to believe that the person is really suffering due to something happening in the brain. The chemicals in the brain are disturbed. Next. There are certain information given which suggest the lifestyle changes, which are very important for patients group also and for the caregivers group also, where we talk about the nutrition, the importance of exercise, the daily routine, time management, work management, communication, spiritual support, yoga abhyas, and daily routine can be given some kind of a leisure activity which can help them enjoy life. Next. As I said, there are number of myths which color our patient's mind and our caregiver's minds. A lot of times they believe that mentally ill person is having low intelligence. त्याला काय कळत नाही. He doesn't have buddhi. So to clarify all this is also important. Mental condition is only when there is a trouble one has to consult. Nothing can be done to prevent mental health problem. So we need to sort out by discussing, we need to encourage people to talk about how they can strengthen social and emotional skills, seek timely help and support, develop supportive, loving environment at home, and also have positive social environment and healthy sleep patterns. This is more so because of this technology and people getting addicted to the screen. Yeah, next. Many more myths are there and we all are aware. But to share a few, mental illness, mental health condition, mental illness is a sign of weakness. All mentally ill are violent. Mental health condition can never recover. There is no correct medication which can really improve the patient for a longer time or for lifetime. And counseling is just talking. This is also one common myth. This is true not only for social workers and psychologists, but also for psychiatrists. They say te nusto boltat. Their medication is sleeping pills. About addiction as mental health problem, it is nothing but lack of willpower is one common myth. They say that if he decides he can stop or she decides she can overcome this. People with schizophrenia have split personality, and mentally ill people can never be self-employed, or they can never get a job, or they can never get married. So there are huge confusions, myths, and misconceptions about mental illnesses, which are there in the minds of caregivers. So they require a kind of educative session where there is a proper systematic discussion over all these important aspects of life. Next. Now I would like to share a few cases where psychoeducation has played an important part, and psychoeducation, because it was not practiced or the caregiver did not cooperate for psychoeducation, the result. Now this was a girl, 15-year-old girl, who was referred for disinterest in academics and anger issues. Very intelligent child. She would score some 94-95% in the school. And on probing, we got the history of maternal aunt having psychosis. The girl had sleep issues. She avoided socialization. She had confusion, loss of interest. She would often talk about fears, trouble getting ready for school, absenteeism, occasional violent behavior, and muttering to self. Her mother was a general practitioner and father was an engineer. They belonged to a higher middle class family. And the girl was brought because of her muttering to self and that abnormal behavior. The treatment was started, and we encouraged the mother to attend the psychoeducation group. Mother and father, of course. Father refused. He said, I have no time. Mother came and she attended the group, but she had discomfort sitting with those other group members who belong to slightly lower socioeconomic strata, and also they talking about certain major symptoms, active symptoms of schizophrenia. Now this was a psychoeducation group for caregivers of schizophrenia patients, because the girl was eventually diagnosed to be having psychosis and schizophrenia. Now here the mother had lack of acceptance, and she was also confused about whether to, though she was a GP, she was confused about the treatment adherence. She kept feeling that the girl has problem with the menstrual cycle, and so this treatment is not really to be continued. And so she shifted her to homeopathy treatment. Between the husband and wife, there were issues, and those issues were also affecting the child. The girl was becoming lonely. There was huge stigma. There was guilt in the mother because her sister was suffering. So there were couple issues and there were family issues. The communication in the family was affected. The girl had side effects of medication, due to which the girl was totally shifted on homeopathy treatment. And occasionally when the mother would come, she did not talk about the homeopathy treatment and altering the medication prescribed by our hospital. There were symptom increase. There was psychotic depression. The mother would suggest the girl that she should focus in studies more than her symptoms and stop muttering and control her symptoms on her own. the loneliness increased and the girl ultimately hanged herself. The sad part was that if the family would have been more positive about attending group or individual psychoeducation groups, maybe we could have saved the girl and the girl would not have committed suicide. Next. The second case I want to share is of a middle-aged married man having extramarital affair. He was referred with loneliness, financial stressors, social stressors, and concentration issues. On probing, we found that there was a breakup in relationship, that extramarital relationship. He was depressed, and his alcohol and smoking had increased massively. He was neglecting wife and child and the old parents. That was affecting the job. Now we attempted counseling to help him cope with the breakup. CBT inputs were given. Also, impulse control strategies were taught. But psychoeducation group therapy for him was effective because he had to manage his depression, anxiety. He was able to share his feelings with others who were also going through the same kind of a problem. The wife attended the group of caregivers where simple techniques like controlling the nagging behavior, the expressed emotions that we talk about in schizophrenia and in addiction, these are the major issues that we have to deal with. Expressed emotions are how you convey your feelings and thoughts towards the loved one who is living with mental health problem. High expressed emotions causes increased risk of relapse, which involves sarcasm, hostility, or overprotectiveness. Now, in this case, where this man was suffering from addiction, we helped the wife and the family members. Of course, one of the parent would attend the group, and we helped them understand that he is going through a mental illness where he has to be supported and this nagging has to be stopped first. When he was on treatment, we had to respect his motivation to continue the treatment. He was trying, he was making an attempt. So critical comments and hostility had to be controlled, which was helping this person. Emotional over-involvement of mother had also to be controlled. We explained the wife that there is use, abuse, tolerance, and dependence, the stages in addiction. And we help the person understand that keeping money with you or focusing more on job, but keeping money with family is more important, not to handling money. That is one of the important behavior change that he has to make. Also, involving himself in some hobbies, building new relationships, regular meditation or yoga. He was fond of namasmaran. Then reviewing old forgotten skills. All these things started helping him deal with addiction problem. So psychoeducation group acted as support. His sharing with the group gave him some courage to deal with the problem that he was going through. Case 3. Now here is this 68-year-old professor who came with memory issues. He had behavior change. Family was confused with his changed way of handling money. Once he handed over a bundle of ₹100 to a taxi driver. And then ultimately the family brought him to the hospital where he was diagnosed to be having dementia. Family psychoeducation into so many things where he would forget the toilet door or he could not unlock the door after entering. Simple tips to manage his daily routine were given in the group therapy session, psychoeducation group. Also, the family was helped to understand that he forgetting the name of daughter-in-law or the grandchild is because of his memory, recent memory getting faded. And then as the sessions progressed, the family was so supportive. It was, of course, a very educated family. They themselves also thought about different methods to handle him better, and they wanted him to be happy in life. So I remember they took him to his college where he was a professor, and they celebrated his 75th birthday in the college, where he remembered most of his old friends and peons and the laboratories where he would work. So these were the three very prominent cases that came to my mind. So what I feel that when a person is going through such difficult life situations, the caregivers also need a support to share, support to get solace, and uh, support for catharsis. Recently, I went through a severe grief situation, and I had my set of family members, my cousins, my friends, with whom I could share a lot of things, and that helped me a lot. So, caregivers, when they are lonely through this process, when the patient is unmanageable, sometimes the behavior is shameful behavior, which cannot be explained in the society. Society members do not accept such a person, so they require a strong support from the therapy center. Here we have to remember that efforts of the patient, efforts of the caregivers have to be appreciated, praised, and not the outcome. Sometimes the outcome is not up to the mark, but the effort has to be valued so that the self-esteem is intact. And they, with this protected self-esteem, they try further and they really help the patients. During my course of whatever number of years, 30 years or plus years, I have seen so many successful such sessions where the patient's family has really helped the entire process of patient's life. Next. Now, psychoeducation with social perspective. Here, I just want to highlight certain efforts as a society or at large that we do. Awareness workshops in schools and colleges, mental health exhibitions, posters, handouts, discussions, which are very helpful. Involvement of school counselors or NGOs who are actively participating in such causes are also to be encouraged. Early identification is very important. I remember many films have come. Marathi film Devrai, Beautiful Mind, 16 Park Avenue are also very strong and helpful media. So dissemination of such information for caregivers helps, and awareness in social groups help in protecting and helping our patient population. Next. There is one simple take home message that nobody is 100% mentally ill. Somewhere there is a healthy corner of mind which is intact, which has to be searched, stretched, and increased. Staying healthy might be the most important quality of a good caregiver. A lot of times we come across caregivers who are totally neglecting their own treatment or their own life, maybe due to expressed emotions, maybe due to the feeling that they have to devote their life for this loved one. But then at the same time, they have to take care of themselves. They have to eat well, get enough sleep, exercise regularly, and if they have a mental health issue, they have to also approach a therapist and seek support. Next. these are some important pictures, how we, some people may feel nostalgic looking at these, because these are the regular sessions that we conduct in the OPD, where we use posters and handouts and information booklets, and we encourage a healthy discussion between the caregivers and the patients. Next. I believe that there is a creation of a problem, so there is a creator. So I believe that I have to call God and end with this serenity prayer. God, grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. Thank you.
Thank
you so much, madam. It was a wonderful presentation, and your 3 case summaries talked about 3 different aspects of psychoeducation and how it has to be used in our clinical practice.
Yeah, thank you.
Actually, I believe that psychoeducation is one of the major aspects of psychiatric treatment. One important issue why we need a lot of education is the stigma that is attached to variety of mental illness, the cost of treatment, the length of treatment, and also the sacrifices that the family has to make to look after the different mentally disabled persons. So, to control lot of anger, lot of aggression, to control lot of hurt, and to control a lot of depression in the carers is also very important aspect of psychoeducation. Once you understand the what things are and how they are to be managed, they can very easily be managed. And we really need major help from the, I call them psychoeducators. So very well done, madam. Thank you so much for your talk.
Thank you. Thank you, sir. Anybody have questions?
Thank you so much, Sadhna. It was really, I remembered some of the cases and some of the sessions, and I hope that the residents have learned a lot from this. If you have any questions, please ask so that ma'am can answer before we go to the quiz.
Lakshmi ma'am has asked, ma'am, could you throw some light on the challenges you have faced during psychoeducation?
What is it? I could not hear. What?
Ma'am, the challenges you have faced during psychoeducation, some personal experience about your journey, some examples.
Yeah. As I shared in my first case, I had a severe feeling of helplessness because I could not, help that lady who was a general practitioner. I kept believing that she will understand the best of what we were trying to say. But due to stigma and the couple issues, which were very difficult for us to handle at once. So sometimes you feel helpless because of the number also. In our kind of public health institutes, I feel there is a need of 100 more therapists who can reach out to so many who are really in need of such support. So these are the challenges when they need you one-on-one and for a longer time. The quality interaction between the therapist and the caregiver or the patient is very much essential in certain situations. Also, there are certain areas where the travel distance, people are coming from far off distances. They come from interiors of Maharashtra, they come from interiors of Uttar Pradesh, and they have no support over there whatsoever. They are trying to earn their livelihood here in cities. So we need many more such services all over India, I feel. Only then we can be healthy, mentally healthy population.
In extension, if I may ask, I have a query.
Yeah.
Your name and what chairpersons or an other seniors.
Yeah.
specific scenario where the lack of information or awareness is not the problem, but some kind of emotional hurdle is related to
I
stigma
cannot hear
and
you properly.
causing some form of. Hello, am I audible now?
Yeah.
Yeah, so the question is when there is not the issue of awareness or information, but some kind of emotional holdup that is leading to stigma and problems in communication. How to go about that in psychoeducation?
Actually, when it is a group session, there are other members who are also sharing the similar situation. Sometimes these questions are better handled by the peer learning experiences. They also talk about what happens in their family, what happens, how they deal with it. So that is one. Secondly, if we ask them to focus on the key areas when the communication or the emotional outbursts or emotional issues are more, we give them the space to for emotional discharge. They have to talk about all those negative emotions which come up, and then one by one we can deal with that in a group session. That that helps. I wish we had some videos also of such live sessions which are conducted, and also empathetic understanding of the therapist and the other caregivers. Sometimes if it is only information which is imparted, they find it very dry, or they cannot relate to it. They feel, to me doctor hai म्हणून you are sharing this. You come to our situation and see how my patient behaves at home, or my patient behaves with the neighbor, or how shameful it is to be with this person who is an alcoholic and who is drunk. So then you cannot say, okay, come on, I will also experiment and stay. But then if you can express that empathy through your talk, and you can reach out to them, that you really understand the pain, they feel supported, and then they are more positive in finding the solutions. The solutions are with them. We are nobody to give them the ready-made solutions. They are the ones who sort out, they deal with their own issues and problems. They know the best how to handle this, but we just have to motivate them to be more attentive to the resources which are around them, is what I feel.
Thank you. We invite no queries. We should take advantage or benefit of such a learned person who has a lot of experience. So want to ask direct ask to ma'am also. We'll have some time. So meanwhile, I would like Shilpa ma'am to share a few words.
No, I was just listening to Sadhna, and I remembered that there are some other challenges that we can face in patient group. Is that, there are some patients who may not cooperate, or there are some patients who have personality issues, or there are some patients who might get aggressive in the group session. So I think the person who's conducting the group also has to be aware of this either from the beginning, so that you don't include that person. And if you have included that person, then maybe we need to know how to handle it in the group. Otherwise, the doctor or the person or the social worker or the counselor who's standing there might be at a loss as to how to handle this. So we have to be prepared for such situations. There can be emotional outbursts also during the group. Like when this group is going on, people share their experiences. there is a lot of cohesion that happens. And because of that, they might have an emotional outburst. So we need to also handle that, because otherwise the whole psychoeducation group can get disturbed because of that. So either we can handle that individually, or maybe we can continue with the group and ask that relative or the caregiver to leave, and somebody else can handle individually that person. So such issues can also come up with in the group itself, and we should know how to handle it. Because sometimes what happens, we are giving all the information, posters are there, it's all ready with us. But when we are interacting with them, we should know how to handle these issues also, because otherwise, just giving information is not psychoeducation. So, what they are going through, as Sadhna already said, that empathetically handling it, that we understand what you're going through, and you can express or say whatever you want to say, and then we can come up with the solutions to how to handle it. So they get reassured that here is someone who understands, and then will also help me find the solutions.
And I
So as
also
she said,
mentioned, contraindication, as I said, that these
Yeah.
patients cannot be included sometimes if they are two
yeah,
personality problems.
yes. I also thanked Dr. Kirpekar for chairing this session, as well as giving his inputs, because he also has a vast experience and has been doing therapy for so many years. So thank you, sir, for your time and for chairing and participating in the session.
I believe that this is something that one should not take very lightly and just pass off any kind of remark when talking to relatives or
Yes,
carers. It has to be done very seriously, because whatever we say remain in their minds for days together, and that affects their interaction with patients and significant others also.
yes. I feel a little preparation is required also before you start conducting a group, because suppose you're alone and you're conducting the whole session, say a schizophrenia family group, or uh, de-addiction, or if you have a bipolar or a depression, there needs to be a little preparation. You can't think of things on the spot, which I feel sometimes residents doing, that they are just you know uh, going with the flow, and suddenly somebody asks something and they don't know what to answer or how to handle it. So a little bit of preparation helps, is what my experience tells me. You can't just go and start the group. You have to know what you're going to speak, you have to know what you will speak with which poster, and what if such questions are asked, what kind of answers I will give. All little bit of preparation is also required.
Sometimes questions related to marriage issues, they
Yes,
want your judgment. Can we get him married? Can we not get him married? So it is patient specific. It cannot be given as a information in the group situation. So these things are very important.
Then it is our job to just give information and help them make their own decision. We can't give decision to
yes.
anybody for any important thing in their life.
So, sir, in continuation to that, sir, any tips on how students can develop better empathy, how they can approach the patient and caregivers?
One thing is they need to read a lot. That madam has done training in REBT. REBT basically deals with emotions and differentiates between unhealthy and healthy negative emotions. And basically it is a technique whereby we can help the client to convert unhealthy emotions into healthier ones. So anxiety becomes concern. Again, when the anxiety becomes concern, the way of looking at a thing changes. So if everybody leads little bit of REBT, some basic book related to techniques, and that will definitely help. Therapy is not very difficult. We are only afraid of therapy, and probably we don't give so much of importance to therapy because we don't have time. But talking, comforting, discussing, supporting, all these things are equally important to medical line of therapy.
Thank you, sir.
We now move on to the quiz section of this session. I invite Dr. Mansi to take over.
Thank you. Thank you, everyone. So I'll request Mr. Yogendra to please start the quiz. Just a pointer before we start the quiz, it's in the form of multiple choice questions. There are 4 answers given, out of which only one is correct. It will be seen as a series of questions. So select all your answers one by one, and after at the end only submit the quiz. Don't press submit after each question. So Mr. Yogendra, please, can you display the quiz? The total time for the quiz will be around 30 seconds per question. We have 10 questions. So this is the first question. Which of the following features points towards poor prognosis in patients of schizophrenia? Your options are depressive symptoms, disorganized symptoms, family history of mood disorders, or paranoid symptoms. Question 2. Which of the following is not an indicator of good prognosis for major depressive disorders? No more than one previous hospitalization, advanced stage of onset, a history of more than one previous depressive episodes, and absence of psychotic symptoms. Third question. Which of the following is the best predictor of the likelihood of attempting suicide in the future? Alcohol abuse, female gender, recent divorce, and prior suicide attempt. Fourth question is risk factors for the development of adolescent substance abuse include all of the following except early onset of cigarette smoking, diminished parental supervision, pervasive developmental disorders, or parental substance use. Fifth question, the now obsolete refrigerator mother theory was postulated to explain the development of which childhood disorder? Conduct disorder, autism, ADHD, or childhood depression? Sixth question, which of the following statements about delirium is true? It is independent of age. It has no bearing on overall patient prognosis. Male gender is an independent risk factor. And post-cardiac surgery, patients rarely develop delirium. You have to choose the correct answer, which is the correct statement out of these 4. Question 7. In body dysmorphic disorder, which of the following statement is correct? Plastic surgery is usually beneficial. Comorbid diagnosis is unusual. 50% of patients may attempt suicide, and SSRIs are effective in reducing the symptoms. Question 8. Which of the following statements regarding rapid cycling bipolar disorder is true? Alcohol, stimulants, and caffeine use are risk factors. It is defined as at least 4 episodes per month. There are no depressive episodes. It is more common in men than women. You have to choose the correct answer out of these 4 statements. Question 9. The etiology of borderline personality disorder does not involve which of the following? Childhood trauma, vulnerable temperament, family history of psychotic disorders, family history of personality disorders. And the last question, which of the following is not true about dyslexia? Dyslexia is neurobiologic in nature. It is characterized by difficulty in word recognition. Dyslexia is a phonological deficit, or dyslexia causes people to read words backwards. You have to choose the option which is not correct, not true. Last few seconds remaining. Achha, so the poll is ended. So we'll share the results. The answer to the first question is disorganized feature is a poor prognostic factor in schizophrenia. The second question, the correct answer is which of the following is not an indicator of good prognosis. So we wanted the bad prognosis is history of more than one depressive episode. Best indicator for likelihood of attempting suicide is prior suicide attempt. Question 4, the correct answer is pervasive developmental disorders. They are not the risk factor for substance use development. Obsolete refrigerator mother theory, the correct answer is autism. It was used to explain autism and schizophrenia to a certain extent. The following statement about delirium is true. Answer is male gender is an independent risk factor. It is the other 3 statements are untrue. Question 7, in body dysmorphic disorder, the correct statement is SSRIs are effective in reducing the symptoms. Question 8, the following statement regarding rapid cycling bipolar disorder is true. The first answer, the first option, alcohol, stimulants, and caffeine use are risk factors. It's a little tricky here because it's defined as 4 episodes per year, not a month. There are definitely depressive episodes, and it is more common in women compared to men, rapid cycling. Question 9, the etiology of borderline personality disorder does not involve a family history of psychotic disorders. Rest everything is present in the family history and in the patient history. And the last answer, which is not true about dyslexia, is the last one, that people read words backwards. It's a common myth about dyslexia. People don't read word backwards. They have difficulty in reading and writing in learning disorders. We will be sharing the results of the quiz with you in the coming quiz, who has topped the highest. If there's any other queries, you can definitely reach out. Thank you. I hand over back to Dr. Nachiketa.
Thank you, Dr. Mansi. We had our President Meena ma'am for a while. I think ma'am was there for most part of the session and she has congratulated Sadhna ma'am for a great session. I know Shilpa ma'am for concluding remarks.
Thank you, Mansi, for a nice quiz.
Thank you.
And I thank our speaker, Dr. Sadhna Bhatkhande, once again for a wonderful session and especially sharing her patient experiences as well as theory about psychoeducation. I also thank our chairperson again, Dr. Vivek Kipekar sir, for chairing as well as for giving his inputs and tips for the residents who were attending. And I hope they have learnt a lot. And please share your feedback on the link given because we are arranging these sessions for the residents based on the residents' feedback only. And therefore, these sessions are coming up. So I hope you attend in large numbers and please share your feedback. Thank you, everyone. Thank you, Nachiketa, for moderating the session. Thank you.